Sure. Good morning and welcome to today's breakfast at UMHealth. And it happens to be the last one before Christmas. We truly apologize for the technical issues earlier. Ladies and gentlemen, it is my pleasure to introduce you to Dr. Aliyah, an emergency physician and a valuable member of our team. Today, she will be presenting on using an improvised oxygen delivery device during the COVID-19 pandemic. Dr. Aliyah is a dedicated physician with a strong interest and publications in critical care, trauma, and resuscitation. She's also committed to advancing free open access medical education and is our moderator for the emergency department's IG page called Updated with an 8. In addition to her professional accomplishments, Dr. Aliyah is also a mother to her son Iman and excels in everything she does. She's a true asset to our team, and we are honored to have her with us today. Without further ado, please join me in welcoming Dr. Aliyah to the stage. All yours.
Thank you, Dr. Muhaimin, for that very kind introduction. A bit of an oversell there, I must say.
Not at all, not at all.
Okay, so without further ado, I will share my slides. So I'll just start off. Today I'll be presenting about NRB and NC. So it's a bit of a jargon. NRB and NC is essentially non-rebreather mask as well as nasal cannula. That is a combined oxygen devices that is actually used recently as an ingenuity by our emergency department colleagues to oxygenate severe COVID-19 pneumonia. So before I begin, again, I'd like to introduce myself. My name is Aliyah. I'm also an emergency physician in Department of Emergency Medicine. That's my email. If you have any questions at all, feel free to drop them there. So everybody might be wondering why we took this topic when UMHealth offered us a slot. And actually speak on the behalf of the entire department, felt like this is a very important topic to talk about. There was a very fateful day on July 12, 2021, at the peak of the pandemic, around 8:30 p.m. I was not on call, fortunately, or unfortunately. A very good friend of mine, Dr. Nabila Azmi, was on call. And what had happened is that there were 18 patients in the respiratory critical zone in our department, and they were all desaturating. Ventilator alarms were blaring. It was very dramatic, and Dr. Nabila was rightfully alerted. So she then had activated the hospital level disaster code to ensure that everybody knows about this situation. Evidently, if patient is desaturating, they are at a high risk of developing hypoxic cardiac arrest because they're not receiving oxygen. So the first thing that we wanted to do was just to get all of our patients out of our department and into somewhere where they can attend to critically ill patients. And of course, the first place we wanted to send the patients to were the ICU. But surprisingly, a similar situation was also occurring in our ICU, and the patients there were also desaturating at that time. So what had happened was that the building actually ran out of oxygen. It was unthinkable, it was unprecedented, and at that time, we needed to keep a level head and ensure that all of our patients are safe. So we were wondering why that could happen. Of course, COVID-19 is in itself an unprecedented event, and this has never happened before. So we wanted to know why and what we can do in order to prevent this from happening again. So after that incident, all of the patients thankfully were transferred into an unused wing in the ICU. But evidently there were some challenges that were involved in that transfer because our staff were not familiar with the setup of that unused ICU. We had to transfer patients, bag them. We had to transfer equipments, and there were also risk of spoiling the equipments or losing the equipments along the way, etc. But that's beyond the scope of this talk. But what we actually had discovered by dissecting all of the events that occurred and doing a post-mortem was that there was actually a severe supply-demand mismatch of the oxygen. What had happened at that night is that the ED respiratory critical zone, we call them RESP1, was at 250% capacity. At that time, 4 patients were mechanically ventilated. 2 of the patients were on high-flow nasal cannula. For those who are unfamiliar with what high-flow nasal cannula or HFNC NC is, don't worry, we will go through that further down the presentation. And 12 of these patients were on non-rebreathing mask. So at the same time, the emergency department's semi-critical respiratory zone, we call it the RESPI 2 zone, was at 300% capacity. Every patient in that zone was actually on average 5 liter oxygen, was receiving 5 liter of oxygen per minute. We have found, after discussion with the engineering department, of course, that the hospital infrastructure was actually unable to cope with such a high oxygen demand. And we just then found out that there's actually a maximum oxygen capacity. There's actually a ceiling in the amount of oxygen that the building can provide for our patients, and it's about 500 liter maximum. If you look at the photo there, that's the liquid oxygen of how our oxygen is being kept. And investigations further down the line identified that high-flow nasal cannula were in fact the culprits. And any time at all there were 2 concurrent use of high-flow nasal cannula, there will be oxygen depressurization. Of note, if there is any amount of depressurization occurring at one time, it will take quite some time before the pressure comes back. So then our patients will just be without oxygen, and that cannot occur. Before we delved further into why we're giving so much oxygen to our COVID pneumonia, this is the pathophysiology of why hypoxia occurs in severe COVID. So we have about 5 pathophysiology, and this is the reason why patients are so oxygen hungry and they're so hypoxic when they arrive to our doors in ED. First and foremost is the happy hypoxia phenomenon. So if you look at this, I hope you can see my my mouse here, just scrolling. So anyway, if you can see on this particular graph, during the symptom onset and at the progression of where the disease is most malignant to that particular patient, they do not present with dyspnea. Dyspnea is a sensation of breathlessness. So what had occurred is that usually this kind of patients will just have a respiratory rate that is somewhat normal. They will not complain of difficulty of breathing. But if you actually check their pulse oximeter, it will be down in the 80s%. Now, just of course, the normal SpO2 would be above 95%. So if they're hovering around 80s and 70s, then evidently the patient is in trouble. And the reason behind that is because most of these patients will have normal partial arterial carbon dioxide. And as we know that it is actually the carbon dioxide that triggers the sensation of breathlessness. So if they come in with somewhat of a normal PaCO2 or partial arterial oxygen CO2, then they will not kind of develop the dyspnea. Next is the intrapulmonary shunting from VQ mismatch. I know this is very jargon-like, but just allow me to explain why we need to give oxygen. So what has happened is that because of the infection, most of the lung parenchyma has collapsed. So they will have atelectasis, there's pulmonary edema, there's a lot of inflammation. And so some of the lungs that are affected by COVID will not be aerated. So this will create VQ mismatch. And some of the cardiac output will not be receiving enough oxygen to be supplied to the rest of the systemic circulation. So this and then will cause hypoxia. Normal lungs will have what we call as hypoxic pulmonary vasoconstriction. This means that parts of the lung that is not aerated, it is almost like the body goes into an automatic compensation by redirecting or shunting the blood to areas of the lung that are aerated. However, this particular mechanism does not exist, or well, not to say does not exist, is particularly impaired in patients with COVID. So again, it will develop VQ mismatch. COVID-19 also causes impaired oxygen diffusion capacity. So less oxygen can be diffused inside the alveolar and also inside the vessels. And of course, of all the endothelial injuries from direct injury from the COVID itself, from the SARS-CoV-2 virus itself, will cause intravascular microthrombi. So all this causes hypoxia. And so when we give oxygen to the patient, we hope that the oxygen that the patient inspire will wash out all of the carbon dioxide from the airway, reducing the diluting effect of the carbon dioxide, reduces the intrapulmonary shunting of blood, reduces the, I'm sorry, this is getting a bit more repetitive, but it does reduce right to left shunt due to the VQ mismatch. And eventually all of that will increase the partial arterial oxygen for the patient. So eventually we will take the patient out of hypoxia. And that's the reason why we give high flow nasal cannula. There were a lot of emerging studies at the peak of the COVID pandemic that were saying that high flow nasal cannula is a great oxygen device that will reduce intubation rate, increase PaO2 or partial arterial oxygen, and therefore increase the PF ratio. So what exactly is a high flow nasal cannula? So if you can see the photo, that is actually a setup of high flow nasal cannula. There's a bit of a kind of a similar structure to nasal cannula at the end. But what happened is that the oxygen is being extracted and it is humidified and is also being heated in order to provide heated humidified oxygen for our patients. So this is important because heated humidified oxygen will actually allow for improvement of mucociliary function, and therefore increases the ability for the patient to get rid of their airway secretions and reduces inflammation of the airway as well. And next, another, I suppose, trait of high flow nasal cannula is that with HFNC, we can meet the inspiratory demands of the patient. So when the patient has increased minute ventilation, which means they're breathing at a faster rate and they're taking deeper and deeper breath, their minute ventilation will increase. As we know, minute ventilation is respiratory rate times by tidal volume. Okay, so what has happened is if they take a faster, deeper breath, it is quite difficult for the amount of oxygen that we're giving them to take them out of their hypoxia. However, because of the large amount of oxygen flow in our HFNC, that demand can be met. Next, HFNC has also shown to improve the FRC of our patients, and this is actually from the provision of PEEP. PEEP is actually a peak end expiratory pressure. Essentially, it is a pressure that allows for air or oxygen to be pushed inside our lungs. So if that occurs, we're increasing the lung capacity and the ability for the patient to breathe, just to kind of put that in a simpler term. Next, HFNC is also a better oxygen modality that's tolerated in comparison to our NIV. Non-invasive ventilation, just to quick recap, is actually being delivered by a very uncomfortable kind of facial mask that covers the nasal bridge all the way down around the mouth, and we have to really put it very snug and tight on the patient's face so they're unable to eat, and then with the amount of oxygen that goes in, the pressure and everything, it's very uncomfortable. So some patients are unable to tolerate them, but with high flow simplified device, and most patients can tolerate them. And with the high flow of oxygen that is being delivered through HFNC, the amount of dilution from the oxygen being delivered is actually much less. Okay, and again, as I said in the previous slide, there's a lot of carbon dioxide that goes that actually stays in the dead space. So if we actually provide a high amount of oxygen, we hope to wash out all of that carbon dioxide and reduce the ventilatory dead space into perhaps a more effective oxygenation for a patient. So HFNC it's got pros and cons. Now you can read your pros on your own. You reduce intubation, reduce length of stay in the ICU, and if you fail high flow nasal cannula and the patient deteriorate, you can still use that as a method for pre-oxygenation. We call that apneic oxygenation. And there was a time where everybody's so scared of aerosolization of the viral particles, we found that actually HFNC has negligible aerosolization, provided you wear adequate PPE. However, it's the cons that kind of make us stave off HFNC, and that is the fact that it consumes 10 more times amount of oxygen in comparison to an invasive mechanical ventilator or a non-invasive mechanical ventilator. So that is a ton more amount of oxygen, especially for us with resource limited setting where there is a ceiling of oxygen capacity. We need to rethink about our options here. We cannot simply just use HFNC and risk other patients who are also requiring oxygen. So this is a photo of a man who's on high flow nasal cannula. So you can see this is the nasal cannula, and it's connected to a humidified machine here. And as I've mentioned here, there's also connected to the wall oxygen where they would receive a high amount of concentration of oxygen. Okay. So after that incident in July 2021, we wanted to rethink our strategies in providing oxygen to our patients. HFNC, we received a lot of donations of HFNC because of the popularity it was gaining at the peak of COVID-19. But it is our resources in terms of oxygen and in terms of cost. And evidently, I'll talk to you later a bit more about how HFNC is rather costly. The tubing itself, this tube that connects to the patient, to the machine, to the patient, essentially will be around 400 to 500 ringgit, and the cost is bear by the patient. So we needed to kind of think about how to deliver and ensure patient safety is not compromised, but also coming up with a more plausible oxygen modality. So we went back to journals, publications, and evidence that are available at that time. And we found that in India and Turkey, they started using non-rebreather masks, which is, I will go through it later, what non-rebreather masks are. And they combined that with nasal cannula, and this was used for hypoxemic respiratory failure, or HRF, in COVID-19, and it has shown promising results. But in India and Turkey, these publications were a case series. When you read case series, they're rather anecdotal. They're not essentially a research. It was just to kind of publish out there, we did this, and this is the result. So, there is still amount of skepticism, and also there is still amount of query whether it would be safe for our patients. And in Turkey, they did the NRB&C for HRF in COVID-19, but it's under ICU setting, and we wonder if it's applicable to our ED setting. So what we did was we then felt like we needed to research this further and to ensure that this is something we can give for our patients, and also not compromise on the oxygen pressures that are available in our building, in our department. Okay, so what is a non-rebreathing mask? So this is a non-rebreathing mask. There's a picture of it here on the left-hand side. It consists of two one-way valves. So there's one-way valve here, and there's another one-way valve here. So oxygen goes in through here, pushes out, patient breathes in, and then the carbon dioxide goes out from the other valve. Okay. So the pros is that it's able to provide about 15 liters of oxygen per minute. It's non-invasive, but the FiO2, or rather the fraction of inspired oxygen that's been provided to the patient, varies. There's no fixed amount. It depends on multiple things. It depends on mask fit, it depends on compliance, etc. So the FiO2 usually goes up to 70 to 90. And if the patient has such a high minute ventilation, the respiratory rate is so much, the patient's taking too much deep breath, this FiO2 is actually much reduced to up to 40% only. So it's not really giving the amount of oxygen that we want to give for our hypoxic patients. Another thing, there are some cons, or rather the pitfalls of non-rebreather masks that I've listed down here as well. So we did this is actually how the setup looks like, the NRB&C setup. So the patient will be on a nasal prong and concurrently will be on a non-rebreathing mask. And what we found is that the results are as promising as what had been written previously in the case series and in the ICU study. So the nasal prong will be on 5 liters of oxygen, and the non-rebreathing mask will be on 15 liters of oxygen. Both are humidified. Okay, so I'll just proceed as to how non-rebreather mask combined with nasal cannula improve oxygenation. So as I mentioned earlier, the FiO2 delivered by non-rebreathing mask can actually reduce down to 40% for higher minute ventilations, okay? So the more tachypnic the patient is, the less FiO2 they're actually getting. But with nasal cannula, as demonstrated by this table here, we actually improve the oxygen and air mixing in large airways. So this will reduce the dilution effect of non-oxygenated air, and therefore increase oxygen concentration inside the non-rebreathing mask itself. So essentially, the patient breathes in more oxygen because we provide them with more oxygen. And the oxygen then from the nasal cannula displace all of the carbon dioxide gas, a rich gas from the dead space, and increase, and this in turn will overall causes an aggregated increase of inspired oxygen to our patient. So you can see if you put here I'm just going to pick a number. Okay, so FiO2 of 70% with just the non-rebreather mask. The moment you add on 6 liters of nasal cannula, it goes up to 80%. And this could mean a change of SpO2 from 88 to even 92. And when you have higher SpO2, the patient will then become less tachypnic and more comfortable. So clinically, you will see an improvement as well, okay? So that's how the setup of non-rebreather mask as well as nasal cannula actually improves oxygenation and also clinical findings in our patients. So it's very appealing. It's a cheaper alternative. Basically, from a high flow mask together, high flow mask is used interchangeably with non-rebreather mask, just to get it out there. So high flow mask or non-rebreather mask combined with nasal cannula is a very cheap alternative. It's about 10 ringgit, if even. And high flow nasal cannula is about 400 to 500 ringgit just for the tubing system, and the patient bears the cost. It utilizes way less oxygen in comparison to high flow nasal cannula. And now looking at all the literature, it sounds safe enough for our patients. So we then come up with a research question. How does non-rebreather mask and nasal cannula actually compare to high flow nasal cannula in arterial oxygenation, or the PaO2, in the intubation rate, in the invasive ventilator-free days, in the hospital length of stay, and also in the mortality of severe COVID-19 patients with HRF, hypoxic respiratory failure. So we wanted to know if we compare head-to-head between HFNC as well as NRB and C, are they going to be comparable? Is one better than the other? So that's why we carried this particular study. Now, what is the definition of severe COVID-19 pneumonia? We followed the WHO criteria, which is symptoms of pneumonia like breathlessness, cough, fever, as well as one of the following, which is respiratory rate of more than 30, saturation of less than 90, as well as increased work of breathing, okay? Just to make that clear. Alhamdulillah, our research, just before we go into the study design, the research was published in American Journal of Emergency Medicine. You can just scan the QR code if you wish to read the paper further, but I will kind of just highlight a few of the pertinent points that we found from our research, okay? So the way we did the study is a retrospective two-center ED-HKL and ED-UMMC, and it's an observational study. Our inclusion criteria is listed as such. They have to have confirmed COVID-19. They would have required non-rebreathing mask and nasal cannula or high flow nasal cannula on arrival, and they have to be in adult patients that are admitted for severe COVID pneumonia. The exclusion criteria, however, are patients that require immediate intubation upon arrival, or if there is a cross-treatment between non-rebreather mask and nasal cannula and HFNC, meaning that the patient comes in with non-rebreather mask and nasal cannula, and the patient then changed the patient into high flow nasal cannula. So these patients will not be included in the study. And actually, looking back at our data, we did not have any patients that fell into this category. And any acute exacerbation of chronic pulmonary diseases, heart failure, or ASRF in pregnancy are also excluded from this particular study. Now, this slide is just to kind of summarize the flow chart, the study flow. Essentially, we managed to screen 531 patients. Now, the nature of our exclusion criteria had forced us to exclude 421 patients, and we eventually made do with 110 patients. And out of that 110, 52 received NRB&C and 58 received high flow nasal cannula. We then followed a 28-day follow-up where we include all of the parameters such as biochemistry, demographic, and also treatment that was given to the patient inside the hospital throughout their stay for the next 28 days. And we found that 28 patients out of the 52 who received NRB&C required intubation. 22 of them de-escalated to conventional oxygen therapy. Now, what does conventional oxygen therapy means is essentially a de-escalation of oxygen that we provide for them. So from high flow mask or non-rebreather mask, we kind of reduce it to face mask and eventually just nasal cannula. So that's what de-escalation means. However, 2 of the patients had DNR and do not intubate order. Okay, so for high flow nasal cannula, out of 110 total patients that we actually followed up, 58 received HFNC. And after 28 days, we found that out of the 58 patients, 22 eventually required intubation. So you can see slightly less, but then we'll make the statistical analysis later. 34 had de-escalated to conventional oxygen therapy and 2 had do not intubate order. Our primary outcome was that we wanted to look into the improvement of partial pressure arterial oxygen at 2 hours. So 2 hours post-initiation of NRB&C or high flow nasal cannula. Our secondary outcome is that we wanted to look into the rate of intubation for these patients, ventilator-free days, length of stay in the hospital, and the mortality after 28 days, and improvement in saturation, PF ratio, respiratory rate, and also eventually to look at whether the patient improved by de-escalation of oxygen therapy or worsened by intubation. Okay, so as I mentioned earlier, these are the data that we extracted, demographics, biochemistry, chest X-ray findings, and the treatment. All of the treatment that were provided to the patients that we included in our studies are up to the discretion of their intending physicians and the availability of the oxygen devices. So in the NRB&C group, the setup is 15 liters of oxygen in the non-rebreathing mask and 5 liters of liter of oxygen per minute for nasal cannula, and FiO2 is determined as 1. For high flow nasal cannula, they received oxygen via OptiFlow, and the flow rate as well as FiO2 is again determined by the discretion of the treating physician. So the need of intubation is determined 2 hours after initiation of the oxygen therapy, and it is based by 2 things, clinical parameters and the ROC score. ROC score, I will delve into slightly deeper in the next slides, but essentially it is a ratio of oxygen saturation and respiratory rate. Other things that we calculate are the PF ratio, the SOFA score, the APACHE 2 score, and the patients were again followed up for 28 days. So this is the ROC score. ROC score is a scoring that we calculate after 2 hours of initiating the oxygen therapy, either NRB&C or the HFNC. Now, ROC score predominantly is being used to assess whether the patient is responding to the high flow nasal cannula that you provide for the patients. So you can calculate according to that formula, SpO2 divided by FiO2 divided by RR. And if the ROC index is more than 4.88, then the risk of intubation is very low. APACHE score has got a long list of rather extensive parameters that we look at that you can read on your own. But I've also taken the liberty to insert in this slide. So what's interesting and the most exciting for me at least is that the results are pretty cool. There were no statistically significant differences in the primary outcome, which is the PaO2 improvement, in the intubation rate, in the ventilator-free days, in the hospital length of stay, and in the 28-day mortality between non-rebreathing mask nasal cannula and the HFNC group. So this is what we've been trying to identify. If we were to start the patient on NRB&C, would there be any differences at all? Turns out it's the same or similar, non-statistically significant differences between the NRB&C as well as HFNC in the parameters I've mentioned in this slide. But unsurprisingly, of course, if you give any oxygen to any patients that have hypoxic, they will have improvement in PaO2, PFR, and also respiratory rate. So we found that if you start NRB&C or if you start high flow nasal cannula, evidently the PaO2, PFR, and RR of the patient will improve after 2 hours of initiation of the oxygen therapy. Very unsurprising, but it is the non-statistical significance between the 2 groups in this particular parameters that we found quite interesting. Busy table. I just screen grabbed this from the paper, but what I've underlined there is everything that is statistically significant. Okay, so we've got RR that basically we want to say that at baseline of starting of the patient's arrival to our ED and 2 hours after initiation of NRB&C and high flow nasal cannula, what's the RR like? So as I said earlier, unsurprisingly, the RR improves, and there's statistical significance in that. Heart rate improves, statistical significance in that. PaO2, PF ratio, and subsequently serum lactate also statistically improved after initiation of non-rebreather mask and plus nasal cannula or high flow nasal cannula. So we echo the previous findings of other trials before us in that HFNC actually showed significant improvements in PF ratio and RR. But what has not been proven before is that there's also significant improvement in our NRB and C in terms of PFR and respiratory rate as well. So this is also a slide basically to kind of just summarize some of the secondary outcomes that we were looking at. So respiratory rate, so the PF ratio and the PaCO2 improvement. Basically, at any box plot with an asterisk, there are statistical significance. The SPO2 had no statistical significance, but anyway, you can still see an improvement after 2 hours with both modalities. Right, so now we're comparing head-and-head between non-rebreather mask nasal cannula as well as high-flow nasal cannula. So I've underlined again what's significantly statistical significant differences between NRB&C as well as HFNC group, but I've summarized it in a way. So we see that PFR and also improvement of PFR is actually higher in HFNC group in comparison to NRB&C. However, it is worth noting that when we delve further into the APACHE score and also the ROC score, most of our patients who were put on non-rebreathing mask and nasal cannula were more ill at baseline. So I suppose what I'm trying to say is that they came in much more ill and sicker compared to the HFNC, compared to the patients that came in and they got HFNC. So it's unsurprising in a way that the PF ratio and improvement PF ratio is more obvious in the HFNC group. And HFNC group actually took longer to de-escalate to conventional oxygen therapy in comparison to non-rebreather mask plus nasal cannula. But that is because what's recommended globally now, it is still based on expert opinions. We are still researching as to what is the best FiO2 for the patients that we can actually win them off HFNC. But right now, the expert opinion globally had said that, well, if you give FiO2 of 0.3, you can be somewhat comfortable in weaning off the patient of high flow nasal cannula. So that is precisely why HFNC group took longer to de-escalate to say face mask or nasal cannula, because you need to titrate down the FiO2 that you're giving via high flow nasal cannula. And once it reaches 0.3, then you take the high flow nasal cannula off and you give them something else like face mask or nasal cannula. So that's the reason why there is longer de-escalation. Next.
Aliyah, I'm truly sorry to interrupt, but I think we've more or less ran out of time.
Oh no, okay.
Yeah.
I have a few more slides. I'll just zoom through, okay? My apologies. So other secondary outcomes showed no statistical significant differences between HFNC and RBNC, as I mentioned earlier. So this is essentially a summary of what I've mentioned. This is a very good kind of summary poster that was done by our primary author, Dr. Kidir. So in conclusion, in resource-limited settings, like ours, like ED in UMMC, NRB and C, non-rebreather mask and nasal cannula is an absolutely viable alternative to high-flow nasal cannula, given the fact that there's similar improvement in oxygenation at 2 hours and no significant differences in long-term outcomes. So having said that, the effectiveness of non-rebreather mask and nasal cannula needs to be further investigated by a randomized control trial. Hopefully, we can do that in our next phase 2 study, or perhaps the next pandemic. Who knows? I'm not asking for one. I'm just saying. Okay, so this is our MAR fund. This is a photo that was sent to our research FOM competition. We have a ventilator management course as well coming up in January. I heard that it's already full, but we'll be coming up with more ventilator courses soon. So for you to get updated about our latest course, feel free to follow us on Instagram. This is our official UMMC Department of Emergency Medicine Instagram, where we update all our talks, our courses, and interesting cases that we see in our ED. And with that, I thank you so very much, and I apologize for overstaying my welcome. Thank you very much.
Okay, thank you for sharing your insights on the use of modified oxygen delivery device in the COVID-19 pandemic. Your presentation provided a valuable overview of the challenges and opportunities associated with this innovative approach to oxygen therapy. It is clear that this device has the potential to improve patient outcomes and reduce the strain on healthcare systems during the pandemic. We have a few questions, and all of them are related to using the HFM. We'll just answer a few. So one question is that how much less oxygen does the NRB-NC use compared to HFM? And can the HFM tubing be sterilized and reused like many other oxygen delivery devices?
Okay. Can I get the first question again? Sorry, what was the?
It is how much less does the NRB-NC use compared to HFM?
Okay, so NRB, so non-rebreather mask, essentially uses only 15 liters of oxygen on the wall, whereas high flow nasal cannula can go up to 60 liters. And if you crank it up further, the FiO2 that you can give for HFNC is also 1. So how much less? 60 minus 15? Give me a sec. How much is that? 45 liters of oxygen. That's per patient. So yeah, that's how much less. And in terms of HFNC tubing to be sterilized and reused to other patients, we have not got any study so far that says that that can be reused. So that's why all patients get a new one, but the tube follows the patient where they go. So for instance, if they get intubated, they just use that particular tube again for apneic oxygenation. Or if the patient fails weaning off, they'll just use the tube again. So basically, I don't think it's something that you can sterilize. It's a one-use thing. Yeah.
Okay. Thank you, Dr. Aliyah. It's obvious Dr. Aliyah is our editor and not our statistician. So as we continue to navigate the challenges posed by COVID-19, it is important to remain open to new ideas and approaches like this one. Your work has served an important reminder on the importance of collaboration and innovation in the overcoming challenges that we face. Like you said, the future pandemic, God forbid. Once again, thank you for sharing your expertise with us. Your contribution to this conversation is greatly appreciated. Thank you, everyone.
Thank you.